Get started with
Yep. Okay, we were recording. All right, good afternoon, everybody. I'm Mary Neubauer, one of the co-chairs of the Milwaukee Mental Health Task Force, and I will get us started on our September 13, 2022 Mental Health Task Force meeting. Welcome. I'd like to start off with our ground rules. And in our ground rules, everybody will be muted throughout the session. Use the chat feature for your questions or your comments. For the speakers, we'll answer as many as we can. Sign language interpreters are being provided support through a service today, so you will not see the interpreters on the screen. Speakers, please say your name before you speak to help with accessibility. And that is how things will work for today. So that is our meeting logistics. We typically would announce the Mental Health Task Force annual membership drive. The membership drive funds support the following: program expenses, maintaining our website, and the listserv, staff time for coordination. Barbara Becker works for Disability Rights Wisconsin and is our amazing coordinator and gets funded through our membership drive. And it's critical. The forums we have, supporting our meetings, developing position papers, legislative testimony, writing funding proposals, and Disability Rights Wisconsin also is our fiscal agent. And we wouldn't have the Mental Health Task Force without the assistance of Disability Rights Wisconsin, and we wouldn't have a Mental Health Task Force without the fiscal support of all of the supporting agencies and individuals that make contributions. And we're changing the structure, so you will not have any materials today relative to membership. It will be coming out in the next several days, and it's going to be changed this year to allow people to submit their membership online and to pay through SurveyMonkey. So the payment will be able to be made online or by check. So we're moving along. We're coming into a new century. Not that we're coming into a new century, but we've come into a new century for the Mental Health Task Force. We're inching along to be able to make it easier and more convenient for people to make contributions to become members of the Mental Health Task Force. So watch for email from Barbara when the membership and information comes out and a link to the survey. And it really, the task force is a unique organization. There's nothing like it that exists out there and that does the kind of work that we do. And you'll be hearing some exciting things being announced in the meeting today. And if you think about the amazing meeting that we had in July and how impactful that was, well, if there was no Mental Health Task Force, you wouldn't have had the opportunity to hear that meeting, to be at that meeting and hear about things that are happening with youth and how we need to take care of our youth. So thank you very much. And remember to take advantage of those membership materials when they come your way. All right, Christine.
Hi, hopefully I'm not muted. Hi, welcome everybody. The other co-chair for the Milwaukee Mental Health Task Force. Thank you for coming today. I am work for the Department of Corrections. I'm a psychologist by trade, and happy to network and be with all of you today and be a member of the task force. Thank you for coming today. I think it's a really jam-packed session talking about services for the people whom we all advocate for and serve. And I think without further ado, can we announce our first speaker, or is she not here? I'm looking in the.
Yes, we are ready to go. Our speaker from DHS is here, so please move forward.
Thank you.
Do you want me to get started?
Just quick introduction. 9888 Suicide and Crisis Line, Brianne Zaborowske is the lead crisis coordinator from the Division of Care and Treatment Services in the Wisconsin Department of Health Services. And she will talk about the 988 Suicide and Crisis Lifeline. Thank you.
Thanks for that nice introduction, and I really appreciate the opportunity to be here today to talk with you all about 988 and the 988 implementation in Wisconsin. Like Christine said, my name is Brianne Zaborowske. I am the lead crisis coordinator in the mental health section in the Division of Care and Treatment Services at DHS. And I've been assisting in the rollout of 988 since I came to the state about 10 months ago. So I'm just going to share my screen here. There's a lot of information to cover, so I'm going to try to keep track of time, and at about 3:30, I will stop and save about 5 minutes or so for questions. All right, is everybody able to see the PowerPoint?
Yep, you have your screen up and we can see it. Thank you, Brianne.
Okay. All right, I introduced myself already. So like I said, I'm the lead crisis coordinator in DCTS. Just a quick disclaimer, 988 is a national service that has operational differences in all 50 states and 7 territories. So although you can use 988 anywhere within Wisconsin, there may be variations in how counties and local providers that 988 counselors connect to within the service for 988. Additionally, themes of suicide and self-harm will be discussed in today's presentation. So I just ask that you please be mindful of your ability to hear information on that topic. And if you need to step away for any portion of this presentation, feel free to do so. What I'm just going to share today is a description of 988 and some of the data showing the need for 988 in Wisconsin and in our country, the legislative journey to 988 and how it came to be, the 988 Suicide and Crisis Lifeline itself and exactly what it is, and implementation of 988 in Wisconsin. So what is 988? 988 is shorthand for the 988 Suicide and Crisis Lifeline. And this became available in the United States to everybody on July 16th of 2022. So it still is in its infancy. 988 centers have counselors employed 24 hours a day, 7 days a week that are trained in helping consumers who are managing and dealing with a crisis situation. They support people in crisis and are able to provide connections to local resources. There's 3 modalities of 988. So there's essentially 3 ways that consumers can access the service. They can call 988 using a landline or a cell phone. They can text 988 on their phone, or they can go to 988lifeline.org and engage in a chat online with a counselor. Why do we need 988? There's a non-exhaustive list of why we need 988. One of the primary reason is that people continue to die by suicide in Wisconsin and in our nation at increasing rates. This information is from the CDC from their 2019 data. And what they found was that between 1999 and 2018, the age-adjusted suicide rate in the United States increased by 35.2%. I will also add that Wisconsin tends to consistently and historically trend higher in suicide rates than the national average. In 2019, suicide was determined as the 10th leading cause of death overall for people in the United States, claiming just under 50,000 lives. It was the second leading cause of death among younger individuals, ages 10 to 34. The number one cause of death for this age group is accidental injury. And it's the fourth leading cause of death among individuals between the ages of 35 and 44. One statistic and point that every time I read it, I find myself being surprised is that there were nearly 2.5 times as many suicides as there were homicides in our nation. And I think the reason that this surprises me is because we hear so often of the homicides when really suicide is claiming lives at a much higher rate. Additionally, why we need 988, not to at all minimize the impact of a suicide-related death, but it does represent a small proportion of individuals who experience suicidal thoughts and behaviors and non-suicidal self-injurious behaviors, and 988 is for those folks as well. It offers support along the spectrum of crisis experiences, whether someone's having ideation, intent, or they're engaged in an attempt, or they're not having any suicide-related thoughts at all. So the legislative journey to 988. So suicide and mental health advocates began considering the possibility of what a easy to remember 3-digit number for individuals in crisis to access, what that would mean for individuals accessing crisis services. And what they proposed was a 3-digit easy to remember number that's not attached to an already established service. So it's not already attached to, say, 211 or 911. So with this information, they went to their state and federal leaders, and Representative Chris Stewart, a Republican out of Utah, sponsored the National Suicide Hotline Improvement Act. And it was signed into law 4 years ago in August of 2018. And essentially what this act did was it took that idea for an easy to remember 3-digit number, and it directed the FCC in conjunction with other advocacy agencies to study this request for a 3-digit number. And what that report found was that indeed an expansion of 211 or another 3-digit number would not be the most effective way to support national suicide prevention and crisis contact centers. And instead, a single purpose 3-digit dialing code that's unique to this service would provide a platform that can be more easily integrated in society and enhance public awareness about the different functions of each 3-digit number. So a key point in this is that they wanted this number to be easily integrated in society. So just like we learn about 911 when we're in grade school, they wanted to, in an effort to decrease the stigma of people seeking mental health and crisis related support, they want 988 to become embedded in our society. So then with that information and with that report, the National Suicide Hotline Designation Act then directed the FCC to designate 988 as the Suicide Prevention and Mental Health Crisis Hotline on or before July of 2022. So what that July 2022 deadline essentially was, it was the deadline for all telecom carriers, all phone services to have access and programmed into their systems the 988 number. So if someone texts or dials that, they are able to get connected to the National Suicide Prevention Lifeline. And now I'll move on to what that National Suicide Prevention Lifeline is. So in the spring of 2022, the NSPL, or the National Suicide Prevention Lifeline, transitioned to a new name, and that new name is the 988 Suicide and Crisis Lifeline. So even though the name has changed, the service that it provides of receiving support by a counselor over the phone, through text or through chat is essentially the same. The NSPL was created and has been around since 2005, and it provides 24/7 free and confidential services and emotional support to people in emotional distress and individuals who are experiencing a suicide-related crisis, and it serves the entire country. Prior to July of 2022, the only way to reach and to access the National Suicide Prevention Lifeline was by calling the 1-800 number that's on this slide right here. This 1-800 number is still in operation. It's going to continue on indefinitely as a legacy number. So people can call this to reach 988, or they can call the easier to remember 988 number. So now that it's transitioned over to the 988 Suicide and Crisis Lifeline, I'm going to share a little bit about that information and what that looks like. So 988 is administered by a nonprofit organization called Vibrant Emotional Health. And Vibrant Emotional Health is funded by the Substance Abuse and Mental Health Services Administration, or SAMHSA, which is part of the federal government. 988 is a network of over 180 accredited crisis call centers across the country. As of July 2022, 988 routes calls through their network and then connects that caller to a local crisis center based on the person's area code and the first 3 digits of their number. So if you have a Wisconsin number, 608-920-715, is 414 still an area code? I believe it is. 414, any Wisconsin area code. If you call 988 on your phone right now, you will be connected to the Wisconsin 988 provider, the Wisconsin Lifeline. If you happen to take a trip tomorrow to Utah, and you're in Utah and you use your Wisconsin phone number and dial 988, you will still be connected to the Wisconsin Lifeline. So it is not, geolocation has been discussed as an option. Right now, it is not implemented, and there's still discussion on the federal level as to whether or not they are going to implement geolocation. Just some additional historical NSPL data. Call volume has increased approximately 14% each year since the NSPL started in 2005. With 46,000 contacts they received in 2005, rising to 3.6 million in 2021. The NSPL received over 20 million calls from people in distress between the years of operation. Over 95% of people who contact the National Suicide Prevention Lifeline are looking for support, help in coping with a crisis, or connection to local providers. And emergency services are dispatched to consumers in the event there is imminent risk for only 2% of the calls. And I'll talk a little bit more about that coming up here. So what does 988 mean for people in Wisconsin? Wisconsin has one singular 988 and crisis lifeline, which is located in the heart of Wisconsin. I actually don't know if it's located in Green Bay. I don't know if Green Bay is actually considered technically the heart of Wisconsin, but considered where it's located in the state, I'm going to claim that. And we call our Wisconsin Lifeline Center the Wisconsin Lifeline Center. It is part of a larger behavioral health organization which serves individuals in Northeast Wisconsin called Family Services of Northeast Wisconsin. And the Lifeline Center at Family Services is staffed with trained counselors that answer 988 calls, chats, and texts that come in. So what happens when a person calls 988? So a call starts with a person seeking support or a family member. When they dial 988, they can dial 988 and talk to a counselor, they can chat it, or they can text it. If they call it, they will first receive an automated response. The automated response will welcome them to the Lifeline and ask if they are Spanish speaking and would prefer to be connected with a Spanish speaking counselor. If they press 1, they will be connected to that Lifeline. If they stay on the line, they will receive a second prompt asking if they are a veteran and if they want to get connected to the Veterans Crisis Line. If they don't press 1 and don't want to get connected to the Veterans Line, they stay on the line and their call will get routed to the Wisconsin Lifeline, where they will connect to a counselor. The counselor will begin engaging them in a phone conversation, asking them the reason for their call and how they may be of help. The most common experience received by 988 contactors, which is true for over 90% of the contacts, is the person receives support, a de-escalation or assistance in their crisis. They learn new coping skills, they get information on local referrals, and they may receive a follow-up call from a counselor if they're wanting that and agreeable to that. Follow-up calls are completed on the individual on all individuals who express suicidal ideation or greater, or if there's a clinical need for a follow-up call. For individuals who are at high risk of imminent risk to themselves or someone else, the phone counselor with consultation with their clinical team will request a wellness check from law enforcement. If there is imminent risk of harm to the caller or someone else in their area, which basically means there is an active suicide attempt taking place, emergency dispatchers will be contacted to arrive to the person's home. This is just some information I'm going to go over real briefly just for the sake of time, but what it does is it highlights the reasons that callers and contactors to the Wisconsin Lifeline have identified as their reason for calling. And the reason that it's important to point this out is the primary reason is mental health related, but the second reason is related to relationship and interpersonal concerns. And I think what this highlights is the vast majority of callers that call the Lifeline, like this next slide will point out, indicate that they do not have thoughts or intent of suicide. Rather, they're calling and utilizing 988 almost as a crisis prevention service to help to de-escalate that crisis before it gets to the point where a person feels as though they are having suicidal thoughts or want to engage in an attempt. So 988 callers at imminent risk. Vibrant, the Lifeline administrator, has had a policy that's been long withstanding regarding callers at imminent risk. Since the launch of 988, this has become more of a topic for discussion, and a lot of advocates have questions regarding it. So they did issue a clarification on their policies and procedures. So the 988 Suicide and Crisis Lifeline Administrator provides all 988 centers with imminent risk policies that is based on their research of the concepts of suicidal capability, intent, and desire. They promote active engagement and least invasive and least restrictive intervention practices be engaged and provided to callers by phone counselors as a way to reduce the need for a more restrictive intervention or an active rescue. And active rescues for callers to 988 can be initiated by a counselor with or without the person's consent only when imminent risk is present and when the caller is unable to secure their safety. And the Wisconsin Lifeline does have 24/7 clinical supervision available to them at the center, as well as leadership on call. So statewide preparation for 988. The Department of Health Services has been engaged in the planning and implementation of 988 since the get-go. In February of 2021, we were awarded a 988 state planning grant, which spanned the course of the year. And through these funds, we were able to start a 988 planning coalition, which continues to meet monthly. We provide advocacy. We created new policies and procedures with our Lifeline Center and with Crisis County Lines, and we're able to provide funding to the Wisconsin Lifeline Center. When that grant expired in February of 2022, we were awarded a SAMHSA grant, which started in April of 2022 and spans the course of 2 years. The primary focus of this grant is to build capacity at our 988 Lifeline Center. It's really to promote the hiring of staff to be able to take all of the calls, chats, and texts that are coming into 988. Additionally, with these grant funds, the 988 Center was able to expand their leadership team to include more clinical supervisors and outreach providers. They're exploring a remote workforce and assessing the need for additional space and resources within their center. 988 collaboration with existing resources. Although we know that the vast majority of callers, chatters, and texters will not need any additional resources outside of that 988 contact, some do need additional help. And what counselors at the Wisconsin Lifeline Centers then do is they will do a warm transfer to county crisis programs to help consumers get connected to those more intensive crisis services. And if there is imminent risk or the concern for imminent risk, they utilize 911 centers or public safety answering points to get those consumers that help that they need immediately. Funding for 988. The National Suicide Prevention Act of 2022, which maybe I didn't touch on earlier. I think I may have taken that slide out, but it gave states the authority to pass legislation that essentially uses telecom fees to help fund 988 operations. And this is actually how 911 is funded in most states, including in Wisconsin. We are advocating for a telecom fee, but right now Wisconsin does not have that. And what we're doing is we're currently breeding different funding sources of federal and state funding, including our grant funds to support 988. What's next for 988? So DHS and the Wisconsin Lifeline continue to meet regularly with our statewide partners to capitalize opportunities and to address any challenges and troubleshoot things as they come up. The Wisconsin Lifeline continues to hire and train more counselors and supervisors in order to meet the demand of 988. The Wisconsin Lifeline will be transitioning to a new software platform for call center staff in 2023. So they're preparing for the rollout of that. And DHS and the Wisconsin Lifeline are planning to broadly market and message 988 to the general public in spring of 2023. We want to use the time between the July launch date and spring to really build up capacity at our centers before we market it more broadly. And lastly, do you have any questions?
If you want to maybe take down the PowerPoint now and just checking the chat to see everything. This is Barbara Beckert here, just looking at what we have here. So here's the person who asked this question did say it was answered, but I'm going to raise it anyhow because I think it's an important one. She asked, are line monitors treated differently than past suicide hotline? Are they trained with QPR, ACE, or are they mental health counselors or something else?
Yeah, that's a great question. The Lifeline administrator Vibrant does have certain training requirements for all of their centers. What Wisconsin has done though is the Wisconsin Lifeline trains all of their Lifeline counselors to comply with DHS 34 requirements. So all of the Lifeline counselors are trained just like county crisis staff are trained.
Thank you. I see that Denise Johnson has a question. Denise, I don't know if you want to enter it in the chat or how you'd like to handle that. We're working with an interpreter service, so I know that's frustrating.
Oh, no, that's fine. That's
For
fine.
Denise, I meant not us.
Okay.
Well, while we're waiting for Denise to see if she can get some assistance with sharing that question, I'm wondering if she might be asking about how deaf and hard of hearing consumers are going to be supported.
Yeah, I can answer that question. Deaf or hard of hearing consumers, they can utilize the 988 in any modality that they choose. So if they choose to call into this service, they can use a relay service of their choice if they have access to one, or the counselors have access to TTY as well. They can also utilize this service through chat or the text features if that's what they want. For other consumers who may not speak English, I'll just add, then the Wisconsin Lifeline uses the language line, and they'll access the language line for consumers. They do have a Spanish speaking counselor currently on staff, and are looking also to, hire bilingual counselors as well, including the Hmong population.
Thank you. I'm not, Denise, I'm sorry, we're having some technical issues. One other question, and I know you addressed this a little bit, but a concern that I've heard from some people is the perception that if they call for help, that law enforcement could be contacted, and there's a lot of anxiety about that.
Yeah, there is a lot of anxiety, and that has been a topic that has come up, especially with the launch. I will say a couple things on that. There was one misconception that 988 providers were trained by law enforcement and staffed by law enforcement. Like it said, that is not true. If maybe there was a law enforcement officer that wanted to work at 988, they would be trained they would have to meet the requirements for that and go through the DHS 34 crisis training. But law enforcement are only called when there is imminent risk. So like I had mentioned, if someone was in an active attempt and it was a life-saving measure, law enforcement will be contacted, or if they were unable to safety plan with a counselor and were indicating that they were going to be harming themselves. Vibrant and the Lifeline are it is their mission to provide a life-saving service in the event where that's necessary. So that is a value of the organization and a mission of the NSPL or the Wisconsin Lifeline. Should there need to be that level of if there's that level of risk, and should there need to be that contact. We have found that that's true, though, in very few cases.
Thank you.
All right, I think that wraps it up. Thank you, Brianne. And
If you have any questions, please feel free to email me, and I'd be happy to answer them or help to direct you to someone who can.
Great. Okay,
Have a good afternoon, everyone.
thank you. Okay, we can move on to our next agenda item. And many of you are expecting Jennifer Bergensen, who is out of town. So we have a new guest here at the Mental Health Task Force meeting today from Granite Hills. And we have Deanna Meyer, who is the Director of Business Development. And Deanna is filling in for Jennifer. So welcome, Deanna.
Good afternoon. Thank you for having me today, and happy to step in for Jennifer, although she has big shoes to fill. So hopefully I can live up to that. But I'm happy to be able to provide an update to the group on Granite Hills progress today. We're excited to continue our partnership with the behavioral health leaders of the community as our healthcare system transforms. Granite Hills Hospital remains committed to increasing our healthcare teams as to further support bringing on additional psychiatric services to the greater community. We understand that this system change will require ongoing collaboration and a commitment to continuous improvement. We recognize there will be changing roles and responsibilities as well as staffing challenges across all care delivery settings that will impact capacity, yet we are committed to working through all issues to ensure we serve the behavioral health needs of our community. And I have a list of questions here that was provided ahead of time, so I'll go ahead and go through those. The first is, what is the current census and what is the current capacity for adults and for youth? And what is the timeline for being at full capacity? So our current census is 24 adult inpatients, which will be increasing as we continue to add staff, and we'll also be adding a capacity of 6 youth beds targeted to open later this week. We'll continue to increase our census for adults and youth as we bring on additional nursing staff to adequately and safely open additional beds. It's anticipated that we will reach 2 adult units and 1 youth unit in 2022, depending on staffing. And at full capacity, many of you know, we'll have 120 inpatient beds, which will take some additional time to achieve. If there are patients who are uninsured and or have been detained and there is no capacity at Granite Hills, what happens? So Granite Hills has a contractual agreement with BHS to serve as a primary receiving facility for involuntary patients. It's assumed that all other inpatient behavioral health providers in Milwaukee County will continue to receive involuntary patients as there needs to be a continued community response to meet all the needs of our population. If Granite Hills is unable to accept an involuntary patient from BHS or the MHEC due to capacity, the referring agency can either re-refer the individual the next day as discharges occur and or seek services at one of the private healthcare systems. If an individual requires a higher level of care, BHS will review whether placement at another setting is more appropriate. BHS and the county are working on a bed hold procedure. Currently, during this transition, BHS and MHEC are priority customers and referral sources to Granite Hills Hospital. The next question, workforce issues are so challenging right now. What is the current status of positions on the leadership team as well as other positions? Is there any way we can be helpful, you guys, with getting the word out? So all members of our leadership team have been hired and are working to build their appropriate teams. Leaders, including the chief nursing officer, intake director, and interim chief medical officer have all been hired. The positions that continue to be the most targeted and are in the most need include our nursing staff, our intake clinicians, and our mental health technicians. So the way that any of you all can help is just to continue to share the word that we need folks to take care of patients in a very patient-centric focus, and to visit our career website for the current list of openings. Can you share specifics for discharge planning and aftercare? How is their coordination with the county? So our Director of Clinical Services has hired discharge planners and social workers to participate in that discharge planning activity. This includes bringing community service representatives from the county to Granite Hills that have provided education on connecting individuals to care in the community. The county / BHS has been a great partner in providing assistance with legal services and education to our new psychiatric providers. Several community service personnel have also come on site to share their resources with us and provide contact information as to identify patient care teams. We continue to increase our knowledge of all services and will continue to improve as we continue to need to meet the needs of our patients. When patients are admitted, how have wait times been? So we have had a little bit of a challenge balancing the number of referrals for a limited number of beds, which can lead to a little bit longer wait times or requests for referrals the following morning. We're monitoring our referral wait times as well as the time it takes for patients to be transitioned from our intake unit to our inpatient setting. As new staff are trained on required processes as to assess and admit patients, wait times will continue to be a targeted improvement opportunity. Is Granite Hills utilizing certified peer specialists, and can you tell us the roles they have taken on? Granite Hills will hire a peer specialist as we expand our clinical teams. We value individuals with these experiences and will move forward soon. We intend to hire for this position as we expand. This position will be posted on our website, and we look forward to interviewing interested candidates. I think that was the whole list of questions that Barbara sent us. Are there questions in the chat? Should I open that up?
Deanna, this is Barbara. I
Hi.
see one question that has been posted in the chat is what type of outpatient services do you plan to offer?
We will be offering intensive outpatient program as well as partial hospitalization program. We are working to get the IOP open. We are approved to have services, but right now we are trying to maintain our focus in providing the number of inpatient beds that are needed to serve the community. There's only so many resources, and so we're focused on getting inpatient open. Oh, 2 new messages. Let's see. Are you open for business now? Yes, we've been open to serve patients since January, and we're providing inpatient services for patients in mental health crisis for adults 18 and up right now. Any idea how long it will take to contract with MCOs? We're in the process of contracting with MCOs. We had started that process months ago, and we have secured contracts with quite a few, and we're working with others to solidify some of those contracts. Oh, will patients with opioid use disorders be discharged with Narcan? How will you treat co-occurring SUD? So we do not provide any detox or initiate any substance use medication therapy for substance use disorder. Their mental health has to be their primary condition. Otherwise, we would refer them to an appropriate facility to treat their substance use disorder. When adolescent opens later this week, what type of specialized training do your staff on that unit have working specifically with youth? So we do have a psychiatrist that is trained in child adolescent psychiatry, and I know that some of our nursing team and has had some experience working with youth. If there's additional questions on that, I'll probably have to defer to Jennifer to get additional details on that. What are you doing to market to understand communities of color that you are available to care for them? Brenda, I will have to get back to you on what the clinical team has done on that side. I'm not on the clinical side. So if you wouldn't mind, I would like to be able to respond back appropriately based on their training on that. How can a client in crisis access inpatient services? So there's a variety of ways that clients can access inpatient services at our facility. The first is that we get direct referrals from the MHAC PCS, which is only going to be here for a short time. And then also from hospital emergency rooms and other community partners. And then our intake team is available 24/7 to provide assessments for patients that would present for an assessment. If a patient is there involuntarily and does not have insurance, are they billed for their stay at Granite Hills, or is that covered by Milwaukee County? So if the patient is referred to us and is a county patient, and there are some nuances amongst that, and I would not say that I know all of the details around the billing side, but there are conditions around which Milwaukee County would be the payer. And then for other instances, if the patient is here involuntarily, yes, sorry, I didn't read that. So if they are here involuntarily, if they don't have insurance, the county would cover their services. Yes. Voluntary gets a little different, but wait times are understandable. Is there a trauma-informed area where people can wait to get care? So the wait times we haven't had much wait times for patients waiting to get an actual assessment when they present at our facility. We do have 4 assessment rooms where we have patients that either self-present or that are transported from other facilities. We bring them in through our Sally Port and then bring them to our assessment rooms. And so then they, within a few minutes, are generally seen by one of our intake clinicians. And we do have a waiting room if they aren't able to go into that area. That is a room just right off of our main lobby for patients that come to our facility. If I didn't answer that 100%, let me know. Important question about billing. Mike Lappen will be here a little bit, so this can be asked of him as well. Yeah, I would say that that's probably his area of expertise, but are there more questions, or did I answer everything fully? I'll make a note of the one that I have to get back to you on.
Yeah, I'm sure that there are more questions. This is Barbara, and encourage people to continue to put them in the chat. So I guess one of the other issues, and I'm not sure that this was asked there, is how are you approaching coordination with the new mental health emergency center? Because I assume that patients who are being seen there in some cases will be transitioned to Granite Hills, and just wondering how that will be managed and some of the logistics with that.
So I know I can, from having many meetings with Jennifer, that she is very heavily involved with meetings that happen monthly at the minimum with the entire leadership team that is part of the rollout for the MHEC. So I know that she helped work on the teams that created the workflows and has been in good communication with them. Kevin Klusner has been in touch with our intake group. And we've been providing feedback back and forth. I actually stopped in to just say hi yesterday and check in, as they are newly opened as well. So, you know, we are working to prioritize those referrals coming from BHS as well as the MHEC.
And we'll have Mike Lappen here just a little bit later in the meeting, and had asked him to address some of the current transition with PCS closing and the Mental Health Emergency Center taking on the role of PCS. So more to
Great.
come later in our meeting. So stick around, folks.
Well, I might get you ahead of time here if no one else has any additional questions.
Yeah, this is your opportunity. This is a big transition. So, there we go.
How does Granite Hills collaborate with community-based responder models? Montreal, can you maybe help me understand what you might be referencing when you say community-based responder models?
Montreal, you can speak.
Good afternoon, everyone. I am joining you guys by phone via iPad as I pick up my son from school. So I will do my best to keep my eyes on the road and say this. There are so many different organizations out here. For example, Street Angels, Community Task Force, that actually intervene and help in situations where police may have arrived on the scene and a community-based responder may be better outfitted to help and support that loved one. There are times where some of the best things for the person who is in need is to get some professional help, like coming to a facility similar to Granite Hills or Rogers or the Mental Health Emergency Center. The question is, what type of relationships are being established, and what is the process to strengthen those type of collaborations when considering a community-based responder model like the ones that I mentioned?
So I have one team member on my business development team. Her name is Jennifer Ellis. So the two of us have been working to meet as many folks as we can in the community. I know that she had met someone from the Street Angels, and we've been reaching out to folks. So we are happy to meet with a whole host of individuals. We've given lots of different tours of the facility, and we're here to learn about the services that are available in the community and to, you know, to be able to partner the best that we can. So I would say if you would like to work with us and continue to build that relationship, or know folks that would like to learn more about the hospital and how we can continue to build and solidify those relationships, to have them reach out to me.
Thank you so much. If you don't mind, send me your email in a direct message.
I will do that, and I can put my email into our chat and it will be there as well, but I will definitely send that to you directly.
Thank you.
You're welcome. All right. No more talking. Keep your eyes on the road.
Okay, any other questions? All right, thank you very much, Deanna.
Thank you for having me. And Jen will be back next time.
All right,
Yeah. Thank you so much.
Thank you.
thank you.
Okay, next up, I thought I saw two Koneaznys on the in our meeting today, so hopefully Pete is here. Pete Koneazny is going to talk to all of us about the Karen Avery form in November. Attorney Pete?
Okay.
Thank you.
I'm here. I don't know why you saw two of me. I think there's only one. But just a quick overview, because there's still moving parts to confirm and all that. But the Karen Avery Forum, to mark the date for, is November 15th at 2 to 4:30 p.m. And it looks like it will be co-hosting with, will be hosted by the platform with, but the forum, it will be the Karen Avery Forum Turner Hall's assistance to have the electronic formatting for that. And the topic this year, we have the keynote speaker, which will be a joint presentation or a multi-headed keynote speaker, will be representatives of Rise magazine from New York City. And they have an online magazine and training and advocacy and peer support for family, child welfare involved families. So the theme of this is that the panelists, local panelists yet to be named or be filled in on that, is the approach or the theme is listening to the voice of families directly involved in the child welfare system, with the emphasis on what is needed for community and mental health support for those families to minimize race inequity and to minimize removals and terminations of parental rights by providing the structural supports and things that are most meaningful for those families. So that's the general overview, and we'll have panelists, and then we probably will be having one or two follow-up to make this a series focusing on some of the developments in local programs that are along the lines of supporting families, both in mental health and housing and other related intersecting types of issues that impact families. So that's my overview. I'd be happy. I have a lot of things that we have to get confirmed. So, but if anybody has any questions about the approach or anything, I'd be happy to fill in anything I can briefly.
Any questions in the chat?
Pete, this is Barbara. I just wanted to mention that we have a really great planning committee that is working on this. And if this is a topic that gets other people interested and engaged, please feel free to reach out either to Pete or to me, and we'd be happy to include you in the planning committee. It's such an important topic and has been something that we've talked about for some time about providing more education and advocacy on. So would welcome involvement of other task force participants.
Yeah, I think the November 15th, I think we're pretty well set. We have to firm up a few things before we talk about them publicly. But the other, we have two follow-up events most likely to make this a series. So we're still shaping those thoughts and what we will feature there, but around the themes of supporting family, peer support, intersecting mental health, race equity, gender, all those things. So a lot of different angles on this. So definitely contact us if you have some ideas for what might be in those complementary presentations we'll have in the subsequent events after November 15th.
And Pete, one of the things we'll have to do is notify the Wisconsin Peer Specialist Initiative, because this will be continuing education for parent peer specialists for their recertification. So people will be able to attend virtually. Are we doing the hybrid or is it going to be virtual, Pete?
It's going to be virtual. I met with Emilio from Turner yesterday, and it sounded like they're not quite ready to go with hybrid events. And also their participation in their platform involves about 7,000 people who will be able to attend this.
Okay.
So that is, his preference is to do it all virtual. We'd have to, rent some huge monitors or something if we tried to vary for that, because he doesn't quite have that capacity in their large room as yet. Maybe in the future, maybe for one of the follow-ups, but for right now, we're planning on being faces on screens, and hopefully we'll keep it exciting nonetheless. But may have to
Peter,
let me know if, what things, if there's anything specifically for people to get credit for this, if, X number of the minutes have to be devoted to talking about peer stuff specifically. I know with lawyers, they're real picky about minute by minute on your agenda, what you get credit for, but let me know if there's more to that. We'll try to make sure our speakers check all the boxes for that.
I can talk to you about it. It's a topical situation, and this fills the topic.
Pete, I think
Okay.
Dr. McManus has a question for you.
Oh, thanks. Can you hear me?
Yes.
Okay, thanks. The question is, okay, in this, what you're having is the children's court judge. I don't know if Murray is still over or something, but are you having somebody that can speak or discuss the judicial issues related to it? The Black Health Coalition has been an advocate for looking at what's happening with child welfare for the last 15 years. So I end up getting a lot of information, but
Yes.
I'm very concerned about the Families First Act. I'm assuming you're familiar with that.
Yes. Well, there will be some of that. I think the focus of the forum in particular, the first one, the follow-ups, we may drill down on some specific things. Try to not make this legal. It's more going to be focused on listening to the voices with lived experience, or with RISE, it's people, those are all people with lived experience. And also they are kind of the funnel and conduit for first person narratives and stories of people experiencing the system. So I think, the first thing is,
yeah, but that's what I'm talking about, Pete. I'm not
hearing
talking, I
from
just
those
mentioned,
people before nuts and bolts.
okay, I just mentioned the Families First Act because it's extremely important in terms of what's going on, but I wasn't suggesting that be the primary piece. But the Black Health Coalition has been working around advocacy around this issue for at least the last 10 or 15 years. And even this year already, we've gotten 3 children back that was sent out or tried to adopt when they weren't paying attention to the Families First Act. And when the judges found out about that, they made a shift. So that's why I was just asking, because apparently it's not happening like it should be. So no, I'm not talking about just looking at the law. I'm just saying, I don't think a lot of people really understand what it is, but my concern is what's happening inside this, especially at children's court, inside the system, and the fact that we're getting called a lot about families and when you talk to the families and explain the law to them, they're saying, well, this isn't happening, this isn't happening. So we've been working with them. So that was my question. That's why. Yeah.
Oh yeah, I know you and I have talked about the various legal issues and all these intersections in the past. I think we're going to start out with specific of families involved in that. So it's support in those things that hopefully, if those are done right, you minimize the engagement or the involvement in the system and where all those things engage. We're kind of starting at the front of this and support and structural things as opposed to the other, but I think there will be room in the follow-ups to look at specific things that we'll want to talk to you about. Then just a note, Dr. McManus, I'm going to be on a month-long driving trip, so I won't be around between November 15th and October 15th, but between October 15th and November 15th, we should chat about some of this stuff.
Okay, sounds good.
Thank you.
Other questions for Pete? I just want to add one thing about the forum. I know in the era of Zoom meetings being back to back, I believe what was discussed was that this particular meeting is going to be 2.5 hours. And so I know our normal meeting is 2 hours. So plan on 2.5, correct, Pete?
Correct. The first 2 hours will be an hour for the RISE presenters and a break, maybe 45 or 50 minutes for the local panel portion of this. And then there's going to be a half an hour that's going to be the rest of the Karen Avery event. And we may talk about whether there's possibility of having that part in person, because that's more organizational business and awards and things like that, as I understand it. But that is the last half hour will be those celebrations and awards and business part of Mental Health Task Force. Right, Barbara?
Yes, absolutely. That's going to be an important part of the event as well, to recognize some of the great advocates in our community.
And the other thing to mention is November 15th is not our regular meeting date, because November 9th is the second Tuesday of November, and that happens to be election day. So the Karen Avery Forum is the third Tuesday of November this year.
Thank you, Mary. Good point. You know, as people just go on automatic pilot, they might be a week early, but thank you. That's a good thing to highlight early and often.
Did I say 9th? The 8th. The 8th is election day. Sorry. You think I've got the calendar right in front of me and I get it wrong. The 8th is election day and the 15th is the Karen Avery Forum and awards.
Yes.
Well, thank you, Pete. There's only one Pete Koneazny, but we wish we could clone you because you do such great work.
Yeah, one's enough.
And Mary, I think we're gonna pivot to, I don't think Mike Lappen is here.
Okay. I don't know. We've got to see if everybody for item 6 is here. Let's see. I see. I see Chris.
I think they were all here,
Okay.
Mary. I looked through. They were all here.
Okay. All right. So we can go on. That's you, Christine, correct? You're even?
That's right. That is me. Sorry, Mary.
And your lead-in person is Kyra.
Awesome. Thank you, Kyra. We're so happy to see you here. So we had openings on the steering committee. And so now we're going to have a steering committee appointment process. And we want to nominate our steering committee members. But before we do that, each person has a couple minutes or so to introduce themselves to the mental health task force. And I'll call on people since there's an order to our agenda. In an advocate role, David Fleming. David, do you want to introduce yourself in 2 minutes?
Hello, everyone. My name is David Fleming, and I'm an attorney here in Milwaukee and have been for quite a number of years. I'm currently employed by the state public defender, and I work out at the Children's Court and Mental Health Division, actually. And just want to make sure that I say those I'm here as an individual, not as a representative of the public defender office. I don't speak for them at this point, and any opinions I have are my own. But nonetheless, that's my current work experience. But I've also spent a number of years as an administrative law judge for the state and did hearings involving lots of different issues that would include lots of medical assistance, disabilities, food share, child care kinds of issues, anything that the Department of Health Services or the Department of Children and Families handled, I held hearings for. And to back up again to the public defender, I've worked there on and off over the past 30 years and have handled a lot of criminal matters, but also primarily matters out of children's court and in the mental health. So folks who are Chapter 51 or people who have guardians appointed for them, CHIPS cases, children in need of protection or services, as well as the termination of parental rights cases. So quite a bit of experience with those things. I've also worked in the municipal court system in the county quite a bit, and on a volunteer basis, built homes for Habitat for Humanity for about 12 years as a house leader, so built quite a number of homes. And so across that work experience and volunteer experience, what I've sort of noticed is what I view as I have sort of a broad view of mental health issues, and I see a lot of issues across these various experiences that deal with mental health, at least in my opinion. There are a lot of discrimination, there are a lot of inequities, there are a lot of problems with housing, jobs, finances in general. Violence is an issue in the community. I think there's food and nutrition is a big issue in the community. I think that access to healthcare, access to transportation, even Wi-Fi are all issues that affect people's mental health. And I have some experience with a lot of these issues at a retail level, but nonetheless, I think that lets me advocate somewhat for people. And so when this opportunity came to volunteer for the steering committee, that's why I said that I'd be willing to do it. So with that, I will conclude and let you folks move on to someone else. Thank you.
Thank you very much. I think Kyra is going to introduce our nominees.
I am? Okay. Thank you, David. And I think we're going to continue through all the nominees first before we make our recommendation. So I'd like to introduce the next person nominated, and that would be Christine Alstrup. Would you say a few words, Christine?
I will. Thank you. Hello, everybody. My name is Christine Alstrup. I'm employed at Maida House in Milwaukee. You might be familiar with Maida House. We have a full continuum of care for substance use disorder. We also treat mental health along with substance use disorder. We have outpatient services, residential services, and recovery housing. I've been working at Maida House for 27 years. I'm a person in long-term recovery. I've always been interested in and tried to be an advocate for the consumer in everything I do. So I work as a professional in the field, but I also think it's very important to put a face on recovery and to take the stigma away by talking about our recovery in public. So I'm celebrating 28 years on the 28th of this month of being in substance free from alcohol for 28 years. And as I said, I just think it's important that we have the consumer voice at these tables, that we listen to the consumer, we advocate, that we're always conscious of inclusion and making sure that everybody is at that table. It's their table, it's our table. And then we make innovative and culturally appropriate services for our community. So I would look forward to joining the steering committee.
Thank you, Christine. So are you going to introduce now, Christine, or me?
You can. I've got a lot of background noise right now at my house. Thank you.
Okay. Our next nomination individual for the steering committee is Curtis Marshall. Would you be willing to do a few words?
Most certainly, and I apologize if you really cannot see me, but I'm outside of my gazebo and the sun is making it dark in here. Yeah, I am just super excited to be part, to join this committee. I recently retired August 1. I retired from the State Division of Public Health after 31 plus years. And for years, it's always been important to me, to look at mental health and to work and advocate for mental health. Because again, in public health or in any healthcare, we have to really understand that mental health really is a driver of health across the board. And in my work in public health, I realized, and acknowledged that there were disparities and how mental health really was driving, outcome, whether it was good or bad. So I've been part of Miracle for a while. I think I may have presented to this group a couple of years ago, but I've kind of dabbled in mental health along the way. So I think it's really important that we have a more diverse representation on groups such as the task force and steering committee, and in other groups as well, is really working collectively to really address the inequities and to build sustainable, good health outcomes in populations that are most at risk. So I'm just really excited to be here, and that's a little bit about me. At the state level in public health, I did a lot of work around health equity and policy and health equity policy, and I've worked with some of you that are on this call, in a number of ways in the areas of mental health as well as other focus areas as well. So that's a little bit about me. I'm really looking forward to the years ahead and working together.
Thank you, and thank you for your interest, Curtis. The next nominee is Michelle Laningham. And Michelle, are you able to say a few words?
Yes, I am. Hello, everyone, and I am just so excited to become part of the Mental Health Task Force. I am a retiree of over 26 years from Milwaukee County. The last, I want to say 8-9 years, I was at behavioral health. And I got a chance to see up close and personal how behavioral health looked on the governmental side, okay? But when I retired, I was very perplexed and concerned because I didn't think that there was a good enough connection for people to really get an understanding of how to get help for their loved ones if they had a psychotic episode or whatever. And I started surveying some of the churches that I know about, and I started getting information about people really didn't know what to do. They'd say, well, we go to the pastor, we go to the bishop, but then when I talked to the pastors, it was like, they really didn't have a good clue either. And so I was concerned because I know it's hard to navigate when you don't know anybody. And when my mother had come to live with me prior to her death, and we had to transfer her from Pennsylvania to Wisconsin. And so, getting the Medicaid and getting the Medicare and all of that stuff, it was just more than an ocean. And if I didn't know people in adult services, I would have been in trouble. And I got to thinking about that, and I'm like, man, what about people that don't know anybody in the system, don't know how to navigate, don't know where to go? So in 2017, after I retired, I started an agency called Moving Families Forward. And I've been working with the wraparound program over the last 4 years, giving them information from the community. We go to the community face on. We had 8 pop-up shops this summer, where we just went in front of Walmart. We went in front of Pick and Save. We went in front of Pete's Fruit Market and set up our little camp. And we just talked to people off the street and asked them direct pointed questions about mental health and their mindset and their perception. And boy, did we get a great earful, which I did relay back on to wrap around. But in essence, what I found out is that people need to have an understanding, they need to be able to communicate, and they need somewhere to touch base with. And I was hoping that is what our emergency center would be, a place of a nucleus of information for people. And so that really prompted me when Barbara sent the information to me, asking, if I would be interested. I was like, holy, this is great. This is exactly what I need, because I need to be, now that I have been in the community, now I'm not the government girl anymore, I'm a community girl, and I see their side of things. And so that's what really prompted me to want to become, and I had been when I was working for the county part of you guys, but I wanted to become, again, up close, personal, and known by the task force so that I could stay informed, I could stay intelligent in what's happening, and be able to help the community. So that's pretty much what I've been doing since I left the county, and it's very fulfilling. It's good to help people that don't understand and give them, information on what they need to do. We do resources, and we try to help where we can help when anybody has that type of issue. So thank you once again for giving me the honor to be a part of you, and I'm looking forward to working with you all.
Thank you, Rochelle. And the next nominee is Chris Heggy. Did I say that right, Chris?
You absolutely did, and thank you very much.
Welcome, and can you say a few words?
Absolutely. So I'm about 9 years into being a resident of Milwaukee. I'm 15 years deep in the disability community, very heavy on the service provider side. I've been a housing first coordinator, youth leadership coordinator, a behavioral treatment therapist. I've managed group homes in Milwaukee and Waukesha County, and currently I'm a functional screener. Additionally, I've taken my lifelong passion of video gaming and the social capital that it brings and started a nonprofit to equip individuals with technology and support to interact in the digital space. Rochelle, you really spoke to the benefit of having connections, a mentor with lived experience with these systems, and that's entirely what I intend to bring. I've seen in my intimate interactions with people, often in the home, that the mental health system is failing. It's crashing down. There is a major provider crisis. Wait times, recently when I sought a new provider, 8 months out. My insurance gave me a PDF that was 14 pages long. So I am absolutely thrilled to have a voice and put energy and change forward to address the provider crisis. And additionally, recently it's been brought to light that our court system is not equipped to deal with emotional or psychological abuse. Hopefully my voice and our combined efforts can definitely bring some great change.
Thank you very much, Chris. And now the next nominee is Quintella Perry. Would you be willing to say a few words, Quintella? Oops. We can't hear you. No?
I wonder if it's a mic problem, because I know you weren't muted and we couldn't hear you, Quintella. If you wanted to put your comments in the chat, if we're having tech issues, we totally understand. I know how frustrating that can be. We've all been there, right? Why don't, maybe if we would want to go on to the next person, and then we could give Quintella a minute to, put some comments in the chat if her mic isn't working right now. Does that sound good, Kyra? And
Sure.
Quintella?
So we'll come back. We're having trouble hearing you. I think you can either write it in the chat like Barbara said, or if you can call.
Oh, yeah.
You can call in. Oh, there you are.
Yes.
I heard you.
There we go. There we go. Sorry about that. Trouble with Zoom, or whatever's going on. However, I am Quintella Perry. I am a licensed health insurance navigator with Covering Wisconsin. And so Covering Wisconsin, we are a nonprofit project based out of UW-Madison. We help individuals connect with care. Any individual in Wisconsin we can service. There is a whole great team that supports each other, and we support each other in regards to this effort. We actually just joined arms with UW Extension. So we just became part of UW Extension for the Health and Wellbeing Division. And so that is a great transition for us in our agency. And moving forward, what we do, we connect individuals with care. So we assist individuals with the application process for enrollment. If they're looking to be enrolled with the Badger Care program, the Medicaid program, in addition to the ACA enrollment, we connect individuals with those types of programs. We also help individuals transition over into care. So if an individual is losing their Medicaid insurance and they need to seek out employer-based coverage options or details regarding their employer-based options that they are given, ACA enrollment for individuals, even those who are transitioning over to Medicare, we are experts in this process. We help individuals, we support the community, of course. Any individual who is seeking out care, we help to access care for individuals. We help individuals understand the benefits that they're enrolling into. We provide professional training as well. So for individual agencies that are looking to have support with benefit specialists, certified application counselors, or whomever they may feel needs support with helping individuals through the process of enrollment, we also help with that as well. So the reason that I chose to be part of the steering committee is that I have a passion for healthcare. I've done this forever. And then also just being with the agency I am with, excellent opportunities for us to help out the community. And what I noticed, I am Milwaukee based. So I service the southeastern Wisconsin areas, Milwaukee, Racine, Kenosha, and Waukesha. I noticed that there is a need for individuals to navigate, as Ms. Laningham mentioned. There are so many questions regarding healthcare enrollment and the enrollment process. Individuals are not concerned about. This has become a passion, and it has been a passion for me and the individuals who work in our agency to help individuals understand these benefits that they are enrolled in, the benefits that are available for them, and how to use these benefits. So yeah, that was the purpose of me. That was the purpose of me applying to be part of the steering committee. I appreciate the proposed appointment, and I am hoping that during these next couple of years, things will work out very well. Looking forward to meeting everybody and being partnered with everyone. And so I'm gonna put my information inside of the chat so that if individuals are interested, they can check out the website, look at our toolkits. We offer a variety of assistance to help agencies, in addition to consumers, navigate through this insurance world. So thank you for having me.
Thank you very much. And we have one more candidate to share with you, and that is Montreal Kane. You spoke earlier. Are you with us yet? And can you give us a few words about your interest in being on the steering committee?
Thank you so much. Hello all, my name is Montreal Kane. I am a caretaker, and I have a loved one that 5 years ago in September experienced some extremely traumatic events. This took me from being a novice to really just redirecting my passion to understand what type of advocacy is needed, especially when you think about family members who are taking care of their loved ones. And so for the past 5 years, I've been on a voyage to not only be an advocate and to have a voice, but to help influence policy, to make sure that, rights can be spread all across Wisconsin and beyond for different families who are having challenges in the mental health community. By day, I have an organization called MIRA, which stands for Monitor, Engage, Recommend, and Advocate, where I serve as the executive director. We use assistive technology like Apple Watches to read your heart rate, share them with loved ones, share them with community-based responders, and also share them with licensed state clinicians. And so what happens is we believe that basically an ounce of prevention is better than a cup of cure. So our goal is to say, we're monitoring your heart rate. We know that some things are challenging for you right now. And what we want to be able to do is to connect you with the right resources, to use music and art to help lower some of those challenges. Being a part of the steering committee allows me to just really speak on the behalf of those families that know that there's certain numbers that you call at the wrong time of night and they may send you to the wrong place. Or if you need to be able to get into those emergency rooms to be, just a place of comfort for a loved one and to make sure that you can reassure them that everything is going to be okay, that we can do that as well. And so I'm really excited to be here, born, bred, and raised right in Milwaukee, Wisconsin. And thank you all for this opportunity.
Well, thank you very much. I mean, what an outstanding group of candidates to join the steering committee. So I think the next step is to nominate the 7 candidates you've just heard from: Montreal, Rochelle, Christine, Curtis, Chris, Quintella, and David. And I would like to nominate them to be a member of our Mental Health Task Force Steering Committee and really welcome them with all of their knowledge, experience, and passion for what we do. So I don't know the process after my nomination, but there it is.
Well,
I will second the motion. So all those in favor, raise your hand. Anybody in the audience, raise your hand if you're in favor of the panel of candidates. Okay. So anybody opposed? Okay, by show of hands, the 7 candidates have just been chosen to join the steering committee of the Milwaukee Mental Health Task Force. Congratulations.
Awesome. Thank you. Thank you all.
Okay, that's the largest panel that we've ever added to the task force at one time, but we had the openings and we just had some incredible candidates, and I personally am looking forward to the addition of the new members to the task force. So welcome. So now did we see if Mike Lappen's in the audience yet? Or
Mike is with us. Yes.
okay. So okay, so we can move back to Mike Lappen, who is going to give us an update on BHS and the Mental Health Emergency Center.
So hey everybody, sorry I was a minute or two late, but it was a good thing because I got to see all your new steering committee members, so that's great. Glad I got to take part in that. I know we only have a few minutes here, but I did want to give a brief update.
You're the last person on the agenda.
Oh.
So you have 25 minutes.
All right, well that's great. So I guess the sort of headline news, if you hadn't heard, at 11:31 a.m. on Friday last week, the Psychiatric Crisis Service in Milwaukee discharged its last patient ever and closed completely. Today, about the same time, the last inpatient adult patient at the Behavioral Health Services Hospital was discharged. We still are operating a kids unit. We agreed to maintain our kids unit until Granite Hills opens their youth unit. But as far as adult patients go, that really ends a 140-year run of operating a psychiatric hospital on the county grounds in Milwaukee. So it's a really conflicting couple of days for me as the administrator. As most of you know, from day one, when I started, the plan was already to close the hospital and the wheels had been put in motion to close. When I was hired, I believe the promise was that it would be done within a year or so and I could get to work on the community-based system of care that I had some experience with. I came here with zero hospital experience. Well, I came here with hospital experience, but only as a tech and a CNA in a psychiatric unit from when I was a kid. I had zero administration experience. So 6 years later, we've achieved closing the facility after many challenges, and a lot of you on the call walked that journey with me. You know, Mary Neubauer, Brenda Wesley, many others, Barbara. It's kind of hard to recount the whole story because it just was so convoluted, but here we are. And I would say it's a really positive story because the fact that the county has gotten out of essentially the institution business is a positive. But I'm concerned. I know there's always been some controversy, but I will tell you that my personal experience at the Behavioral Health Services for the last 6 years is one of really awe and respect for the many people who've done this work for so long. And really, it's really a thankless job. So I'm sad for the people that we are forced to lay off. Essentially, we did everything we could to keep people in services and keep them, you know, wherever they could to take a position for future state community-based services. But some folks left, some folks retired. Many went to Granite Hills. Many are going to Granite Hills. Many went to the Mental Health Emergency Center, or will now that they are free. But you know, I don't think anyone who hasn't experienced it directly can appreciate the challenges that those jobs present and the day-to-day grind of operating a hospital, especially the last 2.5 years. I will tell you that the pandemic, you know, I think it's easy to get numb to just how challenging it is to operate in that environment. And I take great pride in the fact that we managed our emergency room in our hospital. We never missed a day. We never went on diversion a day. We never turned anybody away. We continued to operate those services throughout the pandemic, and really at a time when they were needed more than ever. And I do think that you know, the era, as we turn the era, I think some folks might say, well, I'm glad they're gone. I'm glad they're closed. But I do believe that there is a missing piece to the puzzle then that will take some time to work itself out. And I'm fully confident that Granite Hills and the Mental Health Emergency Center will do great work. But it doesn't happen overnight. You figure we had 142 years to get our inpatient service where it was. And, you know, the psychiatric crisis service has been operating in its current capacity, I want to say, since 1979. So, you know, there's a lot of lessons learned over that time. There's a lot of individual skill and a lot of passion went into that work. And so I just want to call it out. You know, and some of our staff might be on the call. I have so much respect and gratitude for all those folks. And, you know, the hardest thing I will ever have done is have closed that facility because of that part. But it's exciting to move forward because, you know, you've walked this journey since 2010, where, you know, a decision was finally made to focus on community-based services, to reduce the institutional sort of footprint. Maybe you've all seen me read the statement from January 17th, 1973 that says, Milwaukee should immediately exit the business of psychiatric hospitals and instead move into a period of consultation excellence so that the people in Milwaukee shall experience better services, you know, and they said at that time, of the 900 people in the hospital, 600 could be immediately released this year if the proper services were put in place. And, you know, furthermore, we should not build a new psychiatric hospital on the grounds. And, you know, then of course they built the hospital, and they built it twice as big as the hospital was at that time. And 50 years later, we're finally taking that feedback as it was given. And I think we've really succeeded in achieving that goal. The original goal was to get out of the institution business and instead focus on excellence. So that's where we are today. The Mental Health Emergency Center did open last Tuesday on the 6th. Pardon the restaurant reference, but they did a sort of soft open in that we were open concurrently. And the way we handled it is we directed law enforcement to only use PCS for involuntary cases so that they could have a few days to get through their sort of first protocols and make sure that everything works. And again, a startup is a challenge. There's just, no matter how experienced the people you bring in, you can't anticipate every challenge, every option, everything that goes wrong or everything that goes right. And so they operated for a few days, and then on Friday we were able to close. It was a very busy weekend. They learned a lot. I wanted to just stress that our team has been very involved for months in, so a shout out to people like Linda Oshis and Steve Ellison, Linda is our Chief Nursing Officer. Steve Ellison is our Director of Nursing. Both were heavily involved in helping them orient staff. Dr. Schneider, who's our Chief Medical Officer, has been really has invested hours and hours into making sure that the physicians that are making those treatment director supplement decisions on behalf of Milwaukee County all go through a very rigorous training program. We reduced it to a series of online modules. The doctors must pass, they take a pre-test. So for those who have good experience in our system, if they pass the pre-test, we consider them passed. But majority had to take about a 4-hour course and then pass a test that said that they understood the law as it works in Milwaukee County, and that they understood how the best decisions get made when you're working with someone in a mental health or substance use crisis, and then how to document that interaction. So the quality of the physician care is top notch and remains under the careful eye of the county. And by extension of the mental health board, we anticipate reporting regularly to the quality committee on the quality of those decisions. And we expect nothing more than excellence. And for those of you who know my team, we do not settle for mediocre. And there's a lot of feedback that we're going to be giving them really day to day, hour to hour. We have all made ourselves available to support the Mental Health Emergency Center. And likewise, Granite Hills is led by someone who I hold in great regard, Jen Bergerson. I realized they presented earlier, so I don't want to repeat the previous presentation, but we are working literally hour to hour with them to make sure that people get the best possible care, and that we are doing everything we can at the county level to manage the legal cases, the legal situations. There's a lot of partners out there. I've had some brief conversations with Katie Holtz. I know she's here, and we're going to be meeting in the near future with the public defenders to make sure that that whole picture of managing those cases, which can be really challenging and complicated, that there's no drop off in the quality of the care that people receive, and that everybody gets that attention they need and doesn't fall through the cracks. As you all know, the legal system is really challenging, and that there are folks who do fall through the cracks because of the strict adherence to what is civil rights. The fact that a person can't be held against their will unless they are imminently dangerous to self or others, that they have that diagnosis, and they have a treatable illness. We are always held to that high standard, and we will hold the Mental Health Emergency Center to the same standard, all the while really trying to get people connected to services in a voluntary way, and to really focus our resources, the resources that are freed up by closing the hospital and the emergency room, to expand and continue to improve our entire community-based system of care, focused on alternatives like CRC and the work we've done with non-police mobile. I am told that our future crisis stabilization houses have finally made it through zoning. So just last week, they did make it through zoning. So we will see a new crisis stabilization house emerge in the coming months. I'm told that the Women's Recovery Center was also approved.
Working again, just happened.
So we'll be seeing a new 15-bed program
well,
for women and children. We have seen some uptick in hiring. Some of it was aided by the fact that we transitioned some of our community mobile positions. So because we were struggling to hire clinicians, licensed mental health professionals, we converted a couple of those positions to psychologists and nurses. We've always had psychologists and nurses on our mobile teams, but since we had those staff who were being laid off because of the hospital, we pivoted, and we had a couple of very interested folks who were extremely experienced, who were willing to become part of our mobile response. So we have an immediate influx of great talent and very experienced staff who will now be part of those community mobiles. So the crisis mobile team, as you all know it, and the children's team have a new influx of talent, which we're very excited about. I think you all know that it's a real challenge to hire licensed mental health professionals right now, especially folks that have to work odd shifts and weekends and nights and holidays, like our mobile staff do. So I guess the bottom line here is there's a lot going on. I'm not going to come to this group and say it's going to be easy. In fact, the challenges are enormous. The staffing challenges right now are the worst they've ever been, and I can't sugarcoat it. I would say that all the providers here on the meeting all have open positions. We're all fighting for the same talent. And what we've seen is people are being hired and then they're not showing up for their first day. People with great resumes who look like they're going to be great, and they literally, or they make it through a day and then they say, yeah, this isn't for me, or I have another option, or I gotta raise somewhere else. Mental Health Emergency Center in Aurora, Granite Hills, and Jen Bergerson, they're experiencing the same thing. They've had staff secured for months who then don't show on their first day. It's just a really disheartening and challenging work environment for us because the work must go on. There is no, we can't pause, we can't stop. Our requirements, our services never stop, and we can't let them stop. So it's a great burden, and it puts a lot of stress on all of us. For those of you who know me, since I started here, I started this job with a healthy reddish beard. It is now completely gray. It is definitely a thing, but I guess I just want to make sure everyone knows how committed we are. A couple of brief things, and then the rest of the time we can spend on questions. We have embedded Dr. Mackery, who is formerly the psychologist attending from the Behavioral Health Division's intensive treatment unit, was for many years. We have embedded him with our legal services team and deployed him to Granite Hills to assist them in understanding exactly how the treatment planning should go for people who are in an involuntary situation, helping them make those decisions about when a person is eligible for a voluntary STIP and how does a treatment plan look for someone involved in the legal system. We immediately recognize that that's a tricky thing to learn. And so we wanted to have someone who is greatly experienced in the game and really helping manage those cases in collaboration with our legal team, with Corp Counsel and with the doctors at Granite Hills. He will also be deployed and along with our legal services team directly to the Mental Health Emergency Center for the same reason. We are no less involved, and in fact, we're probably we are over-resourcing this part of our work because we want to make sure that nothing really falls through the cracks and that we don't drop the ball and miss a deadline or miss a time frame. We just want to make sure that that all goes as smoothly as possible. Again, there will be challenges. There's always challenges, growing pains to a new thing, but and of course, we're changing everything all at once, including our locations. And so, if you see a lot of stressed out looks on a lot of faces at the Behavioral Health Service, imagine if in the same week you closed an institution that's been around longer than any of us have been alive, and then you were asked to suddenly move your office, and all of the services you provide are now changing, and it's just a lot. So we are up for the challenge, just like we are always up for the challenge. We look to this group to help us. We need help with recruitment. We need help with advocacy. Housing is a challenge. It's more than a challenge than ever right now, as you know, with inflation. Everybody who pays rent knows that rents go up. Anybody who goes to the grocery store knows that groceries go up, and the people we serve are always more impacted by those things than everyone. These are, many folks with serious challenges, and who often are sort of operating at the fringe of employment and housing and all those things because they have this mental health or substance use issue that they're at some stage in recovery on. And that's just a barrier that we always focus on to try to help reduce. But really, all of us have a role in that advocacy. And frankly, the stigma reduction, the work that you guys do around stigma, we hope helps people seek help sooner so they don't end up in that police car, they don't end up in that emergency detention. I believe you're all aware of the work we're doing with our federally qualified health center partners. I've spoken about it. I believe we finally made it through zoning with our last partnership with Dr. Izzard and his team at MHSI. We've got 2 prescribers assigned who were former PCS docs who've agreed to become outpatient providers. So we've added 2 more psychiatrists, and that was something that was in great demand and really a challenge. And we're about to open our new DHS 35 certified clinic for youth, the Milwaukee Mental Health Clinic on 19th and North Avenue. We're still waiting for our certification, but we did get our occupancy permit. And I just submitted the last piece of paperwork this week. Apparently our check was lost for our clinic application, which I think happens just about every time we send a check. So for those of you who've been involved in these, you know that the checks always seem to get lost. I don't know why. So again, the future is bright, and I'm a positive dude, so I'm trying to focus on the positive, but again, there'll be some bumps in the road. You'll all be part of those journeys, and we look forward to being able to share things like the grand opening for that new outpatient program, the grand opening for our clinic in partnership with MHSI, and really an expansion of all our crisis services. We are hiring. We will be embarking on a very large community education campaign, both about the redesign and the transition and about the opportunities and options here. We are greatly trying to expand our internship, and I have a full-time person who's coming over from the hospital who will take over trying to expand our clinical internships. I want to say we're up to 18. To me, that's the future. That is how we will work to staff all of these programs, all of you. I don't really care if we churn out great graduates who get their degrees and get their hours. If they go to work anywhere, they don't have to work for me. If they're working in our system, that makes our whole system better, makes our whole system stronger, especially when we are able to recruit and develop local talent, especially people of color, people from our community who really want to be here like all of you. And so I was heartened to hear about, some of your task force steering committee members. People are in this because they want to be, this is a field about being mission aligned. No one is going to get rich doing community mental health work, but that's not why we're in the game. That's not why we're here. I really believe we all share this passion for what we do. And, I was an advocate before I was an administrator here long before, and I hope to continue that role as we move forward into what will be a different world for us, from the county standpoint. But frankly, not a whole lot changes. The focus has always been on prioritizing that community-based system of care. So I just talked a ton, but that's really the quick update. We have a few minutes. I'm happy to answer any questions. If I can't answer it, I'll take it under advisement and I'll get back to you.
If there's no question, we'll wait for questions in the chat, but we have some on another sheet of paper here that we can ask you. Some of them you've already answered, but I think I'll throw the lowest hanging fruit here. Where can we actually, thank you for your enthusiasm, by the way, it's very infectious. Where can we find you after PCS and inpatient beds close now? I mean, where are you physically? Where can we
So
find
my
you?
office is still at Behavioral Health Services Hospital, Building 5, but very soon I will be in the COGS building with most of my colleagues. So most of the behavioral health services staff, so the CARS team, RAP, Crisis will all be at COGS. It's a long story and it's a little complicated because there has to be sort of a temporary plan because the state has not exited COGS yet. So there's going to be an overlap. We've got a very creative plan for some temporary assignments and some working at home, but early 2023, we will have plenty of space and we will, for the most part, be at COGS, with the exception of those staff that are going to be working at those partner clinics. So we have, I want to say it's 32 staff at 16th Street Community Health Center. We have staff who'll be working at Outreach. We have staff who'll be working at MHSI, and we have 2 staff at Progressive. The majority, though, will be at COGS.
Thank you. Question from the chat from Kate Schultz. How does payment for uninsured and voluntary patients treatment work?
At Granite Hills. So for Granite Hills, Milwaukee County has a contract. We have a rate and we are the payer of last resort for any involuntary patients at Granite Hills. And the way that works is they just have to demonstrate to us that the payment got rejected. We have a utilization review team that will work the case. Sometimes we can work with that customer to help them get insurance, and then that stay can be paid retroactively. We always try to do that. If we are unable to, then county covers that cost based on our contract rate.
What are the plans for transportation from the Mental Health Emergency Center to Granite Hills or other hospitals?
So that's a great question. So one of the innovations we've made, and one way I was able to preserve some of my fantastic staff, was to create a transport team. So we have hired 12 psychiatric technicians who formerly worked in our BHS hospital in PCS, and they will be operating a 24/7 transport team to transport folks from the Mental Health Emergency Center to Granite Hills, but really anywhere they need to go to get to that next level of care. There will also be some transport done by ambulance because there are cases where people have a medical need that's appropriate. And we'll also probably use a number of other existing options, cabs, whatnot. It really depends on that level of need. For people who are involuntary, we plan to use our transport team We've been operating that team for about a month, and they've done a really fantastic job. I'm very proud of them. They've taken this and run with it, and we have a vehicle. We actually had this plan to put this in place about 2 years ago, and it just didn't happen with the pandemic and the systems improvement agreement. It just got put on the back burner. A blessing emerged about 3 months ago. Our secure transport company fired us. They didn't want to serve us any longer, and they couldn't hire enough staff. So that stimulated our team. Linda Oshis took the lead, and we started our transport team back up. And they did so well, I was able to get everyone convinced that this was the right path. And so we will be operating that service as a service to the people we serve. And really, it's a service to make sure that people get to where they go faster. We really didn't want people just waiting for transport. And when we were buying that from the marketplace, we were experiencing really significant wait time. So we felt this was the best thing for everyone. And it also preserved some really experienced folks and let them be part of our service going forward.
Thank you. What is the backup plan if Granite Hills does not have capacity to accept the youth and adults from Milwaukee County on the planned timeline?
Well, it's a great question. We do have relationships with other community hospitals. So Aurora Advocate continues to take patients, St. Francis continues to take patients, Rogers, and the discharge planning team at MHEC always considers those options. Granite Hills is our primary receiving facility. We have a contract with them to take our involuntary and indigent patients first, but they aren't our only option. The last resort is always the state hospitals, which we don't like to use. Since I've been at BHD, I want to say we've sent 2 people to Winnebago total from Milwaukee County. That is something we try to avoid at all costs, just because we don't like sending people out of town, and because Winnebago can't handle the volume anyway. They've come to be accustomed to us. That is probably the biggest challenge right now. Is until today, we were still operating our facilities. So many staff were still working for us who will eventually be working at Granite Hills. You know, today we probably have the least number of beds available with us out of the game. But that should start to ease over the next weeks and months. And so, you know, it's a daily thing. Most of you probably aren't aware, we usually go into the weekend with 2 or 3 beds total available to us in the community. That's been the case for about 2 years. So a lot of people have done a lot of heroic work to make sure that people get to that level of care that they need. And that people who don't need to go to the hospital go to places like CRC and Crisis Stabilization House, or that their CSP works with them, or that there's some other plan to try to preserve those beds for the folks that absolutely need it. That work continues.
Can we ask you back for future meetings as the dynamic emerges?
Of course. I'm usually here anyway. I like to attend anyway, so I'm always happy to present.
Thank you. Back to you, Mary Neubauer.
All right, back to me.
Oh, I just wanted, this is Carol Heidemann. I just wanted to chime in really quick. I just want to thank you, Mike. I mean, you have done a fabulous job. I know it takes a village, a team, but for really, I mean, the last several years, you have been so dedicated and working with, you know, Universal Health Services with Granite, and just making sure it was really, you know, seamless. And I'm sure, like you said, it's bittersweet, you know, 140-year history. I did attend, it was probably 2, well, maybe longer, before COVID, when you had that open, you had everybody come in. It was a weekend, a rainy day, but nonetheless, the history of just mental health in itself, and how mental health has really progressed from treatments. I remember seeing photos where it looked like those cement bathtubs. Do you remember? But you were there, you know, and it's, you know, I just want to thank you, because, you know, especially when you're working with so many people, and some are losing positions, some are transitioning, you've got buildings and capital, but you did really a nice job. So thank you. I'm sure you spent many hours, well over a 40-hour work week.
Well, thank you for the kind words, but I'd be remiss that there's a great team at BHS. Yes. So many people did so much, and you know, in a lot of cases, I'm just going along for the ride. There's been really a lot of passion in that building, and a lot of folks really
Right.
made this all happen, and it couldn't be any other way. But I do appreciate it, and this is my this is what I do. I'm here because I want to be, and for those of you who know me, it's a thrill to be able to work in my community where I grew up.
Yeah,
You know, and really, I really never lived anywhere else. So thank you.
you're welcome. Thank you.
Christine, I saw your hand up. Was that a,
I was just clapping for the enthusiasm and for Mike.
oh, okay. All right, so basically, we're ready to close the meeting. I want to thank all of our presenters today for joining us. I'd like to, again, thank all of our new members for the steering committee and welcome them to the October steering committee meeting, and welcome everybody back to the October 11th Mental Health Task Force meeting. Have a great evening and see you in October.